So, welcome everyone. I'm Cynthia Mikovits, Chair of the Department of Population, Family, and Reproductive Health, and it gives me enormous pleasure to welcome you all to the 18th Annual Harper Lecture and to introduce our honored guests. Joining us today in the room are several from Dr. Harper's family. His daughters, Mimi Edwards Harper and Jeannie Harper Jones, and his granddaughter, Allie Harper, and two of her absolutely adorable children, Anna and Isaac. So it's such a treat to have you guys here, and extended family members as well, who I didn't even know were in Baltimore. So now you're going to have to be added to the whole set of the activities. So before we get started, I'd like to share with you a bit about Dr. Paul Harper and his incredible legacy. He was a pediatrician, one of the founders of the population movement, and also a firm believer in prevention. He completed his MPH here at Hopkins and was appointed chair of the division and then the Department of Maternal and Child Health from 1947 to 1970. Wow, hard to imagine chairing an academic department for more than 20 years. As his autobiography would share, he was a visionary teacher and leader. He worked extensively in public health, both domestically and globally, a theme that our department has continued to this day. He authored a 1962 textbook, Preventive Pediatrics, Child Health and Development. And what is so striking about that textbook is it basically identified social determinants of health for a whole range of conditions and happenings, including injuries, themes that were just unthinkable at the time that he was practicing and leading the department. But he really thought greatly about the need to focus on emerging problems related to physical, emotional, and mental health. He also commented on the broad social problems of the times and the variable degree to which medical content would address them. He increasingly said that studies would require the actions of multiple agencies, including medicine and public health, and his words couldn't be more true today. Delivering the Harper Lecture this year, we are so honored to have Dr. Greta Massetti here, Professor and Chair of the Department of Population Health Sciences at Georgia State University. Her research addresses the epidemiology of violence against children, women, and girls, and the role of violence as a driver in infectious and chronic diseases. I'm noting a strong life course theme here, something that our departments share. She's co-chair of INSPIRE, a global collaborative initiative co-led by the World Health Organization, and her work focuses on three interrelated areas: strengthening the measurement and availability of population data on violence, particularly in low and middle income countries, assessing the experiences and impacts of online technology-facilitated violence among adolescents and young adults, especially image-based abuse, and translating and scaling evidence to policy and preventing violence globally. Definitely a kindred spirit to many in our department. Prior to her current academic leadership role, Dr. Massetti held numerous leadership positions at the Centers for Disease Control and Prevention, where she led global health initiatives, conducted research on violence, overdose, and suicide prevention, and received more awards than fit on one page of her CV. Her work, like that of Dr. Harper's, focuses on prevention, as well as the social and societal issues impacting public health. And in case any of us think that violence is no longer a current issue, Michelle Decker shared with me a recent post in the conversation. And one of our alums from the university, Katie Spearman, wrote a piece about two really horrific acts of domestic violence that just took place this past month, one in Virginia and one in Louisiana. Really sobering reminders of our need to take advantage of warning signs that are available and doing all we can to prevent ongoing domestic violence. So we're greatly honored by having Dr. Massetti here, serving as this year's Harper Lecture. Please join me in welcoming her, and she'll share her expertise regarding using population data to accelerate national action to prevent and respond to violence. Welcome.
All right, thank you so much for having me. Hopefully you all can hear me. As Dr. Mikovits mentioned, I am from Georgia State University. I've spent most of my career doing work in violence, primarily at CDC for 18 years, but I'm really excited to talk a little bit about some of that work and how it's transitioned to my current role. I'm going to just give you a little bit of a high-level overview so far of what I'm going to be talking about, just a little bit of background, some high-level topics on insights from nearly 20 years of the surveys that we've been working on, a little bit of a deep dive into one country, and then a potpourri of other topics. Before I start, I do want to acknowledge that some of the topics that I'll be talking about today do touch on fairly sensitive issues and themes that are somewhat heavy. So I do want to acknowledge that if anybody needs to take a little bit of time for yourselves and step out, you're more than welcome to do so. Acknowledging that, there has been the topic of violence in the news media quite a lot over the last 10 years or so, and particularly in the last year. A lot of people have been following the release of the Epstein files and the national attention that it has brought to the topic of child sexual abuse and exploitation. And that has really forced a national conversation about a challenging topic that makes many people uncomfortable. And regardless of where you stand on the issues or on the political spectrum, I think one thing that really stands out to me is the fact that we all agree on a common core concept that children deserve to live and grow up in an environment where they are safe, nurtured, and supported in order to have the opportunity to have thriving, healthy lives. And that's really what I've focused most of my career on. And yet that's not a reality for the majority of children. 1 billion children every year experience some form of violence. That's 1 out of every 2 children globally experience sexual, physical, or emotional violence. We also know that violence isn't just a problem because of the immediate impacts on young people, injuries and bruises, broken bones, but oftentimes violence generates ripple effects that reverberate throughout an individual's life. So young people who experience violence in childhood often are at higher risk of issues like injuries and mental health outcomes, but also reproductive health issues like unintended pregnancies and fetal death, chronic disease outcomes like HIV and STDs, chronic infectious diseases, chronic diseases like cancer and diabetes, and a variety of other issues as well. So the work that I've really focused on is contributing to this issue that, as we have seen, when it's often talked about in the media, is why didn't victims come forward? What do we not know about violence that is literally killing our children? And that's really, we don't have data, right? It is an invisible problem, and it's only through speaking with survivors and having better data that we can give voice to the voiceless. We've done that at CDC and with a lot of our collaborators through a system of data that's called the Violence Against Children and Youth Surveys. I'll tell you a little bit more about that. You can see this is a map of every country that's conducted at least one VAX. And since 2007, which was the very first survey in Eswatini, we've done 27 surveys. We've talked to over 120,000 young people in that time. We've built capacity in 25 countries. And you'll notice a couple of things. One is the very first US-based VAX was completed in the last couple of years right here in Baltimore. It was our US pilot. Those data were just released at the EIS conference yesterday. It found fairly striking results. And the other point that I want to highlight is that most of our work has been done in sub-Saharan Africa. And that really has been a recognition of the intersectionalities of violence and HIV in countries that have a generalized HIV epidemic. The goals of the VAX are to assess the burden of violence in its context, to understand its health consequences, identify risk and protective factors, and really guide violence prevention and HIV programs and policies. So why HIV? Essentially, the relationship between violence and HIV, there's been a lot of work that's been done on this topic. It's really about both direct and indirect pathways of relationships. So we know that gender-based violence, particularly sexual violence, affects HIV directly through sexual assault, but there's also indirect pathways. So for example, young women living in violent relationships are unable to negotiate safer sex practices that might protect them from HIV. And in particular, the support that the VAX has received, primarily in the last 15 years or so, they've been funded through PEPFAR, has been in recognition of the challenges we've had in making progress on HIV among adolescent girls and young women. These are data, they're just now a little bit old, but if I pulled up a graph that's more recent, it would show the same thing, that we've seen tremendous reductions at the population level in HIV incidence. But the places where we are stalling and continue to struggle is right here. These are females ages 15 to 24 and females ages 25 to 34. So young adolescent girls and young women are continuing to have HIV incidence, new cases of HIV at an alarmingly high rate compared to the same age peers. And violence has a role to play in that. I love methodology, and I particularly love survey methodology, so I could nerd out on the details. I will not do that for you today, but if anyone wants to know about methodology, I'm happy to talk about it. The VAX are household surveys. We go door to door with young people ages 13 to 24. They're a 3-stage cluster sample survey design. We use a split sample design. So in communities where young women are interviewed, are different from the communities where young men are interviewed. That's in order to ensure that we are not interviewing both potential perpetrators and victims in the same community and villages. They're all carried out in partnerships with in-country institutions. We have lots of, 300 pages of protocols to ensure that we're protecting the privacy, safety, and confidentiality of young people who are sharing very difficult life experiences. And that's also a data quality issue, right? If we don't have the right protections and controls to support young people sharing experiences in a confidential way, they're not going to be comfortable disclosing experiences. We also, in those countries that have a generalized HIV epidemic, we also do HIV testing and counseling to respondents who can receive the results of their own. We talk about VAX as a violence survey, but in reality, it really is a source of comprehensive data. So we have data not only on different forms of violence, but risk factors, gender attitudes, risk-taking behaviors, health outcomes, and HIV. So I'm going to tell you just kind of the plain overhead view of findings over 27 surveys. In general, we have found that violence against children is common across countries. So these are the prevalent ranges for females and males. And you can see about 1 in 2 to 3 out of 4 females, and a little bit more than that in males, experience any form of violence. That's a lifetime prevalence. We also have published a number of studies that have linked experiences of violence in childhood with health outcomes among young adults. And so those are in a few different, these are kind of studies published using data from Lesotho, Kenya, Namibia, and 9 other countries, finding violence was associated with HIV and sexual risk behaviors. We also have data from Honduras showing increased risk for smoking tobacco and binge drinking among young people who experience violence. We've found links with mental health and education among young adults, including suicidality and low educational attainment. And then as well, quite a number of findings related to when young people experience violence, they're more likely to grow up to perpetrate violence if they're boys and experience further violence if they're girls. So this idea of the intergenerational cycles of violence that lead us to need to understand with empathy these violence experiences. Just a few more kind of lessons learned. VAX has really contributed to developing an understanding of the epidemiology of violence as a public health issue. We find that across countries, physical violence tends to be the most common violence against children and youth, and generally prevalence for boys is higher than for girls. And so these are the data for girls and boys, ranges from the lowest prevalence country to the highest. We see a lot of variation in emotional violence for both boys and girls, and then generally sexual violence in childhood is common, with girls generally almost always having higher prevalence than boys, actually always having higher prevalence than boys, even when the prevalence is low. Another point that we have found time and time again across a number of countries is that partners generally are the perpetrators of sexual violence in childhood and young adulthood the first time. So when we ask, this is the denominator here is young people who experience sexual violence in childhood, and then we ask them, did you experience different forms of sexual violence? And they say yes. We ask them, who was the perpetrator the first time? How old were you? And a variety of other questions. And the color bars here reflect different regions. So this is sub-Saharan Africa in green, Central and South America in this reddish orange, and Eastern Europe in blue. And one thing that really stands out is that generally we see a pattern of partners being the first perpetrators in sub-Saharan Africa, but there's a very different pattern in Central and South America and Eastern Europe. And in particular, generally in these countries, it tends to be either an adult who is at least 5 years older than the victim, or a family member who also is, kind of a non-family member adult or a family member adult. So in this situation, it's in these regions, it's much more likely to be abuse by an older person. Another common finding that we have is that early and late adolescence are generally the periods of risk. And so this is, the colors are the darkest is one country, that's Lesotho, and so they're across the board, and it's the age of first experience of childhood sexual violence. And you can see that generally risk for first experience of sexual violence goes up with older adolescents. This is particularly true in sub-Saharan Africa, which is what the countries here depict. And another very stark reality of experiences of violence is that disclosure and access to services is very low. So the first bar here shows across countries, how among those, this is data for girls, data for boys looks almost identical. We ask young people, did you experience sexual violence? If they say yes, one of the questions we ask is, did you tell anybody? And you can see in El Salvador, it's about 72.9, 73%, and it ranges, but it hovers right around 50% as an average. About half of victims have never told anybody about their experiences. Not only that, but is that survey, that interview is the first time that they've ever shared their experience. So again, emphasizes the importance of that rapport and that confidential relationship. When we ask them, who did you tell? Almost always, it's a trusted person, a parent, a relative, an intimate partner, a friend, a teacher, somebody that they trust. We also ask, did you know of a place to go for help? And generally, there's some variation there. We have a kind of a high, relatively more kids in Moldova know of a place in their community where that they can go for help, but generally it's not super high. We ask them, did you seek services? Did you go to a clinic? Did you go to a counselor? Did you go to a teacher and ask for help? And there's a little bit of variation, but it's never higher than 16.3%. So generally we see that about, like hovers around 10% as the average across countries. Only 1 out of 10 victims seek help, which also highlights the fact that when we're relying on data from, for example, administrative records, hospitals, clinics, police, we are missing 90% of survivors of sexual violence because they never even get to the door, much less get help. And then the last lightest color bar is those who receive services. And that is, you'll see kind of the jump from asking for help or seeking help and receiving help is lower, which means that most survivors who are seeking help actually receive it, but it's such a small proportion overall out of all survivors. So that is kind of data from that specifically. I also want to highlight one particular study that we just published this month in one of the Nature journals, Nature Human Behavior, that's really about compiling comprehensive data to produce the first reliable, reproducible, and internationally comparable global and regional prevalence estimates. This is a study that was led by my colleague Xiaoming Feng, who is a health economist much smarter than I am, but we worked on a massive literature search and a Bayesian model to compile data. These are the highlights. I'm not going to go into the detail too much about the methodology, but essentially, because of this massive literature search that returned about 64,000 studies, we screened them down to 1,400 and created a huge database that represented about 7 million young people. We did some data extraction and Bayesian modeling and found that about 1 in 5 girls and 1 in 6 boys experience sexual violence in childhood. These are lifetime prevalence estimates, and you see there's a little bit of variation across regions. We also generated past year estimates. These reflect 2024, and we found that about 130 million young people experienced childhood sexual violence in 2024 alone. That's including both contact and non-contact violence. So non-contact would include someone sharing non-consensual images, sexual harassment. When we just restrict it to contact, rape or sexual assault, it's about 43 million females and 35 million males. And again, we see a little bit of variation across countries. Some general themes from this study. We saw in most regions, prevalence is higher among girls than boys, although we did see a smaller gender gap than we had expected, or than what's been published in previous studies that did global modeling. Girls do continue to be disproportionately affected, but there's a little bit smaller gap, particularly in parts of Asia, Southern Europe, and South America. Okay, so I'm going to take us back a little bit to the VACs in particular. The VACs are not about generating data because knowledge is interesting and useful. They're about generating data to drive national action and change in programming and policy. And one of the core components of that is to establish national leadership within governments on planning and carrying out the surveys. So this is kind of the multi-sector approach that we use from the very first beginning. We establish a single government ministry that is the lead of the surveys. They are in the driver's seat. They bring all of their friends across other ministries, universities, civil society, variety of other partners to the table to essentially establish and ensure that we have government ownership of the data. Whatever comes out at the other side, whatever data, whether it's ugly or nice or tells a good news story or a bad news story, the government owns it because they're driving the process. And the idea is really to use the data as an advocacy tool to break the silence and start a conversation and create action. So I'm going to tell you how we've done that in one country, Lesotho in particular, just because it tells like a fairly comprehensive story. So a few points about Lesotho. If you're not familiar with Africa and geography, it's right down here. It's a fully landlocked nation in the very south of Africa, southern Africa, surrounded by South Africa. It is the second highest HIV prevalence in the world, the lowest life expectancy. It's one of the poorest countries in the world. That's one of the countries that has where adolescent girls and young women bear a really disproportionate burden of HIV. They represent about 10% of the population, but nearly a third of new infections in HIV. And we conducted a survey in 2018 that included about 7,000 females and 1,500 males. So one of the first things we did was, I mentioned we were working with PEPFAR. I imagine some of you may be familiar with PEPFAR. It's a large, it has been a major U.S. government investment in preventing and addressing the HIV epidemic. And in particular, the support that VACs received from PEPFAR was really meant to mention about addressing this disparity for young adolescent girls and young women. So at the time when we did the survey, Lesotho was one of the countries that was implementing the DREAMS program, which was like a package of social behavioral interventions as well as HIV care for high-risk adolescent girls and young women. And one of the things they were really struggling with was they were implementing DREAMS in two districts, two very small districts across the country, and they really wanted to scale it countrywide. And they needed to do some budget planning, like how much is this going to cost? What's our population for this? And how do we plan for that? And so what they were missing is information on who is eligible for the program. If we scale it countrywide, what proportion of adolescent girls and young women are going to be able to be eligible? And so we did some data using VAX to help them identify eligibility. So basically, based on the risk factors that they were identifying, which included whether girls that experience lifetime sexual violence or other forms of violence, sexual risk behaviors like irregular condom use and orphanhood, and a variety of others, which are not shown here because these were had the highest prevalence. Basically, like 2/3 of younger women or younger adolescent girls were eligible, would have been eligible for DREAMS, and about 1 in 2 older young adult women would have been eligible. So that kind of shows the challenges of implementing a program for the highest risk young people in a country where everybody is high risk, when it means that the program could not have really managed the level of eligibility. And so we worked with them to kind of understand, how do you use these data to better target those young women who are at highest risk? We're now rerunning some of these analyses as the country is shifting or has shifted away from DREAMS to planning for PrEP implementation and scaling PrEP for HIV prevention, to use some of these same data to model PrEP eligibility. There it is. We also, there's also a lot of interest. So this was a study that was funded by USAID, also in Lesotho and a couple other countries, where they were really interested. There's a variety of services that they provide through USAID under the aegis of PEPFAR and other programs. But they're trying to address all of these this constellation of risk factors that all co-occur, right? Risk factors like teen pregnancy, child marriage, intergenerational sex, early sexual debut, HIV, transactional sex. Those are not independent and occur in a vacuum. They're often co-occurring. And so there was and in particular, this program was interested in increasing educational outcomes for adolescent girls and young women, and helping girls stay in school. And so we did a latent class analysis, which is a person-based analysis, which really takes this concept of intersectionalities into account and looks at how do these risk factors cluster in groups of people. And we found basically that there's two classes, and you can see them here. There's a behavioral risk class, and it's characterized by young adolescent girls and young women who have high teen pregnancy, high child marriage, and relatively high intergenerational sex and endorsement of negative norms related to gender and violence. And then we also had we had a low risk class, that's this purple line that is kind of low across the board. And then we had this, is that orange, goldenrod class that we called an attitudinal risk class that really was characterized primarily by really high endorsement of gender norms supportive of violence. So things like asking young people, is a man justified in beating his wife if she burns the food, if she neglects the children, if she doesn't tell you where she's going? So that's what characterizes that class. And we found that young women who were in the behavioral risk class had higher odds of low education and intimate partner violence, whereas the attitudinal risk class had higher odds of also of low educational and IPV compared to the lower risk. But the highest risk group was really this behavioral risk class. Another piece we used to really inform programming is USAID was implementing a program really focused on orphans and vulnerable children. That was a kind of a funding cutout of the PEPFAR program in Lesotho, where they had to devote a certain proportion of funding to really supporting orphans. And USAID in country was asking, we know orphans are at higher risk for violence. They're also high risk for HIV. But who are those that among the orphans, which ones should be targeted for interventions? And so we did some analyses, and we were able to identify, this is another paper that was published, that orphans who had primary education or less and were male and were paternal orphans, so the father died, had the highest odds of violence, whereas orphans who had primary education or less were female and lost both parents had the highest odds of HIV. Kind of telling this story of how do you best match services and interventions for young people and ensure that you're reaching them in the way that you need to for prevention purposes. And then I think this might be the last Lesotho slide is some work on disability. One of the ministries we were working with, the Ministry of Social Welfare, Social Development, was really interested in disability. And the reality is, so we added questions in VAX to measure functional disability using the Washington Group Set, which is like a short 6-item measure that's endorsed by global disability groups. These are the first prevalence estimates of disability status from any low and middle income country, interestingly. So we found that about 14% of adolescent girls and young women and 7.3% of adolescent boys and young men had some kind of functional disability, including vision impairment or cognitive impairments. And then this is the prevalence of violence and HIV at the country level. And then when we analyzed the data, we found that young women in particular had higher odds, 2.2 higher odds of any violence. So the blue bars are violence outcomes, the red bars are HIV and sexual risk behavior outcomes. We basically found that having a disability was significantly associated with all of our violence and HIV outcomes. The same was true for boys. The odds ratios were a little bit smaller, and we could not run the HIV outcomes for boys just because the numbers were too small, so the model didn't converge. But this was really important in helping inform PEPFAR programming in HIV care, right? So this allowed them to do an assessment of what do our testing and HIV treatment services look like? Are they accessible? Are they inclusive? When we have young women with vision impairments, do we give them medication that they have to read the instructions for and can't because they have disabilities? Are they even able to reach our services? And so this was kind of a touch point to be able to engage in a variety of conversations, because this is not a small proportion of young women. This is 14% of young women in the country overall. So it's really a need to ensure that our services include everyone. And then one more Lesotho study looking at kind of shifting into discussions about policy drivers. This was really looking at particularly among lowest poverty households. And we had questions about household receipt of government financial assistance. These were primarily cash transfers funded through the World Bank, and also non-government community-based programmings like microfinance, community savings and loans, kind of job training for young people. And we found that in this study, government social protection was associated with higher odds of staying in school, having higher educational attainment, more protective behaviors that protect against sexual risk, and lower odds of child marriage among females, whereas non-government social protection had those households that participated in non-government social protection had young women who were more likely to engage in paid work. So that kind of tells you what one country's story looks like and how we provided those supports to help countries plan. I'm going to tell you a little bit more broadly about the process. We use a data to action process that really starts with the surveys from the earliest days, and then links the survey data to Inspire, which is our technical package. That was the development of Inspire was co-led by CDC and WHO. We launched it in 2016, so it's about 10 years in partnership with the organizations that you see listed here. This was really kind of a watershed moment for the field of preventing violence against children because We would be working with countries, and they would tell us, we would tell them, okay, this is what works to prevent violence against children, and they'd say, that's great. But WHO was in our office last week, and they told us a different story about what works to prevent violence against children. Or UNICEF, we've been working with UNICEF, and they have a different framework. And so tell us which framework to use. You guys need to come together. And so we did. It was not easy. It was not easy. But Inspire is based on 3 foundational pillars. First, that violence is preventable. We need to support survivors and provide services for healing and trauma, but we need to prevent it in the first place, or we will never end the problem. Second, that we need to prioritize based on data, and that preventing and responding to violence should be built on evidence. I don't have slides about this, but we just published in January in the Lancet Child and Adolescent Health a massive systematic review of reviews of Inspire interventions. So kind of really updating the evidence, and showed that every strategy in Inspire has programs that are effective at preventing violence against children. And if I were to, so I do a lot of workshops on Inspire globally, and I have people from all walks of life who attend these. And I often do an exercise where I ask people, if you close your eyes and you imagine a community that is safe, stable, and nurturing environments for young people, where children have the opportunity to thrive, what does that look like? And I invite people to share what they see. They will say things like, it is schools that are safe spaces for children to learn, and they have the maximum opportunity to learn. That's the education and life skills strategy for Inspire. They say it's parents who have the opportunity to be the best, most supportive parents they have, because they don't have the stresses in their life that make it difficult for them to be present for their children. That's our parent and caregiver supports. It's safe environments that children can walk to school and participate in their communities. It's laws and policies and legal systems that create protection and prosecution for victims. It's things like response and support services. So when we unfortunately do have survivors of violence, they have the best quality mental health and health care that they can receive. It's income and economic strengthening. It's resources for families and communities to alleviate poverty and the demands of poverty. And it's norms and values to change the social context that are drivers of violence. So that's what Inspire is. It's 7 strategies. It tells a beautiful story and paints a beautiful picture that we've been working on. The VACs, in addition to a lot of other questions that we include in the survey, but there are indicators for each of those strategies, multiple indicators, usually 3 to 4 for each strategy, so that at the end of the VACs process, we create kind of like a dashboard that countries can see, how are we doing on each of these? Where do we need to invest for prevention? We were funded by USAID a few years ago to do a massive kind of summary of lessons learned from VACs, data to action. This was, we did a landscape analysis, we did survey with 177 stakeholders and in-depth interviews. This is just like the take-home, the one-slide version. This is the countries that reported, and then we did kind of a document review to wherever we could that showed how they used VACs data following the surveys. So you can see a number of countries banned child marriage or closed loopholes, and that's several countries where the age of child marriage, the legal age of marriage for girls, was lower than it was for boys, and they used VACs data to change legal policy. They also were a number of countries where they used VACs data to ban corporal punishment in schools or otherwise, and other supportive infrastructure for social services as well. So kind of the main takeaway with this, what does it all mean? Did we make a difference? So a few data points to show. Kenya was the very first country where we had 2 surveys with comparable data. Their very first, the blue bars show the prevalence of each form of violence in Kenya for females and males in 2010. The purple bars show the prevalence of each form of violence in 2019, and you can see there were significant reductions by almost half for most of them in every form of violence for both boys and girls. That was Kenya with the second survey. We also, just because we wanted to make sure it wasn't a one-off, when we repeated a survey in Eswatini, that was the very first country that conducted a vax. We only have data for girls in Eswatini because the first survey was just threadbare budget, so we only surveyed girls, and we only had similar questions for sexual violence, but you can see for every type of sexual violence, it was a significant reduction, including among girls who had ever had sex. More than half had a first experience that was non-consensual, and that prevalence went down to 17% in 2022. This was a 15-year window. And then just published in the last month, the results from the second survey in Tanzania. The first survey was 2009, second survey in 2024. And again, in that 15-year period, pretty dramatic reductions in every form of violence for females and males across both mainland and Zanzibar, which is part of Tanzania as well. So hopefully one of the main takeaways you can take from everything we talked about today is that violence is preventable and it's possible. We just need to leverage what we know and really build kind of the policy advocacy to put what we know into practice. I'm going to just talk a little bit about the challenges we're facing as a field right now, because there's moments when we all have hope, and there's moments where we all have a sense of despair, and that's rapid cycling for me on a daily basis. And so what I really am trying to focus on, because there's so much we could talk about, is really the data infrastructure that without data, without giving voice to survivors and having a light on the problem, we cannot make a dent. And that's really what's under attack. I've made this point that administrative records, like vital statistics, hospital records, and police are insufficient at really capturing the full scope of violence. The way that we as violence epidemiologists think about it is that they're not a measure of prevalence of violence, they assess the severe impacts, right? Deaths due to violence or hospitalizations due to violence, but they really miss the majority of cases. In order to really get the full scope of the issue, we have to measure using surveys, and those could be violence-specific surveys like that, or they could be modules, so having large-scale surveys that measure health outcomes that also have questions about violence, or special studies like cohort studies and those types of things. Unfortunately, those systems are under threat. The entire VAX team at CDC was eliminated in reductions in force on April 1st, 2025. Many of you probably are familiar with the DHS program and the big question mark that is over that program, and the tremendous source of data on a lot of different health issues that was happening globally. In the US, we had two main data systems. NISPIS is challenged both because of issues with CDC, but also one thing I didn't mention about VAX, we often generally would get between 80 and 95% response rates in VAX. That's the reality of doing a household survey in the middle-income countries. People want to talk to you, or you knock on their doors, and they do. In the US, they don't. If you use a phone, they really don't. And this is a random digit dial survey. And in the last administration, a few years ago, we had response rates that were less than 10%. So we really need to be thinking creatively and innovatively about ways to measure violence. This is a random digit dial survey of particularly among adult women and men. And VDRS is the National Violent Death Reporting System that measures kind of the most severe outcomes. So one thing that's really important to think about is the need to be thinking broadly, not just about single systems, but how do we embed violence questions across surveillance approaches. So these are surveys that are, these all are ones that CDC happens to be involved in. The behavioral risk factor surveillance system has questions about violence. The youth risk behavior survey that's school-based has questions about violence. PRAMS is the pregnancy risk assessment monitoring system, also under attack. But it's on high-risk pregnancies, has questions about violence. The National Health Interview Surveys and a variety of others. So it's really about how can we ensure that we are covering the whole waterfront of surveillance systems and seeing this as a health issue, as a public health issue, so we can kind of embed violence prevention perspectives across the spectrum. A few thoughts on where we go from there, if anyone's listening. The need to continue strengthening our data systems and expanding and integrating surveillance for comprehensive coverage of violence and investing in infrastructure, ensuring that what we're doing is relevant. So how do we generate data that really has meaning for policymakers on the ground, be that a local health department director or state health department director or a senator or what have you. Ensuring that we have mutual connections between data and evidence-based frameworks. I talked a little bit about how we do that with VAX and Inspire, and really needing to translate findings into actionable recommendations to monitor trends and measure the impacts. So I think that is it for me. I did okay on time, so I think we have time for questions. Yeah, great. Sorry, I'm a walker talker, so I just realized well into the presentation that I was standing in front of the reading. So if anyone is interested in my slides, let me know. I'm happy to share them. Questions? Yeah, in the back.
So yeah, I have a question about the methodology. So it's so impressive to, I mean, I wish that we had this kind of data continuing and ongoing. So like there's preaching to the choir for me. I'm interested in how you what kind of challenges you faced in creating surveys that could be implemented across such a variety of countries, and any of the methodological challenges you came up against with things like item wording or making sure that things were relevant to the people on the ground in a variety of different situations.
Yeah, so that is where that multi-sector task force and that local governance and local expertise is absolutely essential. And from both the perspective of, there was an adaptation process where we adapted the protocol and adapted the questionnaire that was really led by government and had lots of experts at the table where we talked about kind of questions. The push-pull there is always, when it comes to questions, is we want to make sure that things are consistent so we know how to interpret it, while also making it relevant. And we had an adaptation manual that helped guide that, but also the translation piece. We had countries like Kenya or Mozambique where we had a lot of local languages, and ones that don't have written language. And so the challenges of needing to really rely on that expertise to help us kind of interpret that. And then also the protocol, there's so much that we had to learn in each country. Things like, when is the rainy season? When do people, it's an agrarian culture. And so this harvest season, they're not going to want to talk to you. And so really kind of needing to have a field implementation plan that was deeply informed by that, by the local needs, to ensure that we had success. And we had that was worked well in most countries. There's a couple places where we encountered some hiccups and learned and went along the way. Zimbabwe in particular was when we had to stop and start data collection multiple times because we didn't have that embeddedness as well as others. But generally, it was really that, we relied on that local experts.
Thank you.
Yeah.
There's a question from Cortland Robinson on Zoom.
Yeah.
Good afternoon. Can you hear me? Is audio okay?
We can hear you, yeah.
Thank you. Really appreciate this presentation for many different reasons, but among them, the focus on evidence to action, which I think we all know in public health there's a gap there. As I look through all the different countries where VAX has been carried out, quite impressive. It sort of raises questions in my mind about populations that may or may not be fully captured in some of these surveys. That would be displaced children, people displaced by conflict or natural disaster or both, including effects of climate change, which are exacerbating. Um, child workers, including migrant workers, people who are working but maybe not necessarily right around the home, but even if they are they captured, and what might be the effects of violence in the workplace? And then thirdly, child soldiers. Has that been picked up in any kind of significant way? That would be probably a burden of violence more specifically on boys, but not to say that girls might not be involved in child soldiering in different ways or affected by soldiers. So just some populations that uh, maybe you could talk about whether in the context of vax or just your knowledge of these issues in general. Thank you.
Yeah, great. So I'll take each of those separately. The first piece on humanitarian settings, conflict settings, displaced children. There's a couple ways that we have tried to address that. One is in places where there is a high proportion of displaced people who are living in general communities. So Ethiopia is one example of that. There's places in Dar es Salaam and in the capital. In a moment, a brain fart. Give me a minute. So in Ethiopia, I'm sorry.
It's Dodoma. Sorry, the capital of Tanzania is
Yes,
Dodoma.
thank you. Sorry, I'm having a moment. I talked about, yeah. So in Addis Ababa, there's a lot of communities where there's people who have been displaced, both internally and from like Somalia or Eritrea. We know that they're living in communities. So we ensured that there were questions in the survey that captured previous displacement. And so then for those who said yes, we had module questions about what happened in your migration experiences. So that was one way to get it that was relevant to a particular country. We also did a project a few years ago where we developed an implementation guide for vax in humanitarian and conflict settings that we then partnered with a group called the Population Council, who then implemented it in 2 refugee camps, one in Uganda, really large refugee camp, and one in Ethiopia, in the southern part of Ethiopia. And so those data, I don't have those, I don't present those, but those are available and have been published on to kind of give us, it turns out the prevalence is actually quite similar, but an important kind of other themes come up around conflict. The last question you were asking about child soldiers, I think I would put that under the larger umbrella of non-household living young people, so street children, institutionalized children. That is a vulnerability for vax. We can only generalize findings to household children living in household. We have included some questions for that ask retrospectively, like when you experience this violence, or you were living on the street, or were you had you been a child soldier. Usually in population surveys, the numbers are not high enough that we can segregate. So that's a missed, like we just can't run those data. So I think, knowing a lot of methods experts, they recommend things more like, snowball sampling and other methods to try to get those participants. I can't remember the second group you identified. I'm sorry.
Child laborers, including maybe migrant workers, but they may be outside the household, so they may not capture the migrant workers.
Yeah, if you're out, exactly. We did do a survey in Cote d'Ivoire, which has a lot of child laborers. That they generally tend to live in some forms of households. A lot of them are child-headed households, so they're just kind of living on their own in cabins or places. And so we were able to collect in Cote d'Ivoire. We do have data on child laborers, but it just depends on the context on whether we can reach them or not. Yeah.
Thank you very much.
More questions in the Zoom. I'll read. Oh, Dr. Page, go ahead.
Thank you for a wonderful lecture. A bit distal to your central point, the issues of transmission, HIV in children with respect to unhygienic conditions, with respect to needles, that are not changed and other issues like that, would it find some focus under your broad umbrella? And if so, has it been looked at or considered to be important enough to include there?
Yeah. You know, we haven't done a ton of work in that area. I do know that in the context of countries with generalized epidemics, PEPFAR has invested a lot of systems strengthening infrastructure to improve so that they have almost eliminated healthcare-based transmission. So, for example, if there's unclean needles in a healthcare system, PEPFAR is really addressing those. They've also, in many countries, they've nearly eliminated mother-to-child transmission during childbirth. And so that's, you know, that's a little bit outside the scope of what we do. There is this larger question of transmission from needle usage, needle sharing outside of healthcare. So we haven't, drug use in most of the countries where we've done VAX is really low among young people. It tends to be more kind of an older population. And so we don't, when we've asked questions, we just don't see that as or they're street children, in which case we'd miss them.
I was thinking of it with respect to immunizations and
Yeah.
issues like that.
Yeah.
So you have a age range that's at risk,
Yeah.
continually at risk.
It's something that we can be thinking about. Yeah, it has not previously come up, but I'd love to think through how we might collect data about that and inform, you know, immunization distribution efforts and ensuring, you know, that our pipelines are clean. Yeah.
Thank you.
Dr. Maria Trent asks, you discussed the challenges with your research. Can you share your thoughts and strategies about conducting research with adolescents who may be experiencing IPV, human subjects approval to conduct? Leaving them out of surveillance creates a gap for public health prevention work early in their relationship trajectories.
Yeah. I mean, I think that's true of any research with survivors, right? And especially those who are currently in a violent relationship. I will say the most important thing we encounter is the need to center survivors on any of our methodologies. So we rely a lot in VAX and in other studies that we do on ensuring that we have survivors and advocates as part of our research teams who can tell us, like, would this make you uncomfortable? Are you okay with this question? Are you comfortable with this, you know, interview style? And that's, you know, having that and having that representation, you know, oftentimes everybody's encountered challenges with IRBs and getting protocols approved. And sometimes it's just well-meaning people who don't know any better, but having the survivor voices being able to speak to that can really help us navigate and understand those potential pitfalls. But I agree, like we can't do work unless when we're blind to it. We need to get the data from the people who are having those experiences.
And I got a message from Dr. Geyer, who also has a question. Go ahead, sir.
Hey, thank you very much. I really enjoyed this lecture and glad to know that you're carrying on some of that CDC work in your new job. I wanted to greet the Harper family. It's been a very long time since I've seen them, so it's a real pleasure to sort of be in the room with you and hope everyone in the family as well. I wanted to ask you a question, though, about your research, which is, what do we know about the perpetrators of this violence and the men? This reminds me a bit of the kind of research that went on 30 years ago in child abuse in the US, where we always put the burden on the moms and the kids to tell us what's going on, but we don't know much about the men. And how do we get that information? What's the methodology for doing that?
Yeah. And do you mean the perpetrators of violence against boys or males who are perpetrators against anyone?
Males.
Yeah. So, you know, we do have a few questions about perpetration, which I didn't show here, but that is in the VAX. We also ask respondents to share who the perpetrator was, and it varies. In general, for sexual violence against girls, the perpetrators are almost the overwhelming majority of time are males. One consistent finding, we see this time and time again in VAX, it's also in the broader literature, is a high proportion of perpetrators of violence are themselves victims of violence. These are boys who often experience violence in childhood, different forms of violence, who then grow up to perpetrate violence against others. It becomes a way that you learn to resolve conflict. It becomes a way to regulate emotion. It becomes a way to exert dominance and power. And so while we have to support survivors, we also have to have empathy for young people who don't learn any other way. And you can imagine if we could identify every boy who experiences violence and reach them with effective supportive services, how many generations of violence could we prevent if we just gave that boy the help and resources they need, right? So that's one way of thinking about it. Another way is thinking about the power structures of broader kind of context, that enable and support violence. I think that's another area where we need to be a little bit attentive to what's happening. Many of you are paying attention to the manosphere and the way that gender and manhood is being talked about nowadays. Those of us who are gender researchers and gender-based violence researchers do have concerns about how that enables a culture where dominance and therefore power and therefore violence is a way that we exert our power. So I think that's worth some broader conversations about what we do about that, because it's a lot more complicated than just get some data on it. Yeah.
I heard in your background that you are researching technology-facilitated gender-based violence and image-based abuse. I wanted to hear a little bit about how is VAX incorporating TFGBV. I know some of the more recent data collection efforts do include it, but just wanted to hear from you in the future how VAX might include it more and more in the work.
Yeah. So in VAX, it has been done a little bit happenstance, depending on, there's always a little bit of real estate on a questionnaire for countries to say, what are the topics you want to add? And so that's been, it's very country by country when they happen to mention that. And then what they specifically want to focus on. So for example, in Kenya, they're more interested in use of social media and more like bullying type behaviors, whereas in Namibia, they have much more in-depth questionnaire about online grooming and image-based abuse. So if you're interested, I should mention, almost all VAX surveys have public use data available. It's available through our Together for Girls partner website. So if you're interested in any of these data, feel free to talk to me and I can guide you through that. So the Namibia data has some great questions. But, it has, part of the problem is that the field hasn't yet come together to have a structured, agreed upon set of definitions. What do we mean by technology facilitated and online violence? And then how do we measure it? And so we were kind of waiting for that to happen in order to be able to add a full module on VAX. We don't have any plans to do, nobody's funding VAX. So there's no plan to do future data collection, but I would love to do that a bit more. But I think, so I'm working with Bloomberg, for example, for those of you who are familiar with that organization. We're trying to convene a group of experts to have to develop uniform definitions for online and technology facilitated violence against young people, or particularly focusing on image-based abuse, and then potentially develop some an agreed upon module. There's David Finkelhort has done great work on this. The Disrupting Harm surveys have done this, but we need let's all come together and agree on, here's the 6 questions you should ask, or the 9 questions you should ask on this. So yeah. Yes.
Yeah. So your data was very encouraging to see that in some places the violence has been declined. So did you try to find out what the causes are? Is there any attributable fractions or attributable causes that may have caused this decline?
Yeah. So one project that we did was following, as we got data from the second Kenya survey, we got some funding to do a qualitative study and a policy analysis of basically tracking what happened between 2010 and 2019 that could explain those reductions. And so that report is available. Happy to share it. And there were a number of both policy changes. So, for example, they updated the constitution for the country of Kenya to close loopholes. So there were some young people that were not fully protected by laws on sexual violence because they were in certain age ranges. And so they closed those loopholes, criminalized sexual activity or non-consensual sexual violence. There was also a massive investment, not necessarily because of just facts, but massive investments from the World Bank and from PEPFAR to support cash transfers, which cash transfers programs are very effective at reducing violence. And that really, we kind of were able to demonstrate a significant investment in those areas that particularly had larger reductions in violence. Also a lot of programming through PEPFAR and others that really supported health and well-being among young people. So I think, there's not any single thing, it's more a confluence of investments of both funding and programming that really supported those reductions. Yeah. Yes, in the back.
I think we're out of time.
Okay, we're out of time. Well, I'm here, so come and back.
Give you
yeah.
thanks and round of applause for being